I'm going to be talking about the prevention of food allergy, as Dr. McGee mentioned. And I suspect that a lot of you are here today because of a food allergy diagnosis in someone in your family. And this talk is going to focus on the prevention. And for some of you that have growing families, this talk is likely very relevant. And I see there's even some young children in the audience. For the rest of you that maybe do not have a currently growing family, you are touched by food allergy in some way. So this talk, I want you to pay attention to and think about it because you are mentors to your friends, to others in the community. And I want you to be able to go away from here tonight and talk to the people in the community about what you've learned. Because perhaps by making some of these changes, we can make changes in reducing the future allergy, both in our families and in our communities. So as you learned from Dr. McGee in his talk about Food Allergy 101, the conditions that we have been living in have changed over the decades and generations. And it is striking when you look at the Amish population how few members of them actually have food allergy. But as you can imagine, it is not practical to expose all of our young children to an Amish dairy farming lifestyle. So that brings up then, well, what can we do in our particular suburban and urban communities to prevent food allergy then? So that shifts us a little bit from allergy treatment to prevention. And the answer to this question about what we can do to prevent allergy is becoming more clear. And this is largely driven by increases in food allergy prevalence over the last 20 years. And there's been a shift in research during that time from treatment more towards prevention. And many recent trials actually have demonstrated that early introduction of allergenic foods is helpful in preventing food allergy. And this is actually a stark contrast to what was recommended only 10 to 20 years ago. So I wanted to briefly go over historical information, and this is only going back, 20 years or less than 20 years. And most of you in this audience are over 20 years old, and you probably recall that we did things differently then. And back in 2000, though, was actually the first time that there was a real recommendation as to what we should do for introduction of foods. And it was at that time, based on mostly two studies that were looking largely at atopic dermatitis, where the AAP then recommended that we should delay or avoid the introduction of allergenic foods into diets. And that went on for some time. And actually, a couple years later, a few big governmental regulation agencies even doubled down on that and were like, yes, this is the right thing to do. But then come around 2008 or so, the CDC put out some data that showed quite striking numbers. And it's actually a little bit more than what Dr. McGee showed in his talk, where we're talking about getting up to about 2% of the population having allergy. I think in some of the data that was coming out, the food allergy was getting up to somewhere near 5% of the population. And so that was when in 2008, the AAP said, well, wait, hold on, maybe we were wrong. And they retracted their recommendation. They didn't go so far at that time to make another recommendation full swing and say, hey, we were wrong, so you actually need to feed these kids foods that are allergenic. That came a couple years later. So it wasn't until more of these sort of landmark studies came out that I'm going to talk about before our governmental sort of agencies said, this is what we recommend, early food introduction. So in about March of 2015, the LEAP trial that Dr. McGee mentioned, and that was when he was showing the peanut protein in your home, and that one really demonstrated for the first time that early consumption of peanuts in infancy is associated with a low prevalence of peanut allergy. So it didn't take long, actually only several months later, before the AAP then quickly endorsed early peanut introduction. And they actually went so far as to say that it was essential that we go about changing the culture of early feeding practices. It took a couple years before we finally found out as physicians what we were going to specifically tell people to do. And that was partially because the LEAP study was just one study. And so by 2017, it was actually just about a year ago now, that both the NIH and the National Institute for Allergy and Infectious Disease recommended some specific guidelines for introduction of peanut-containing foods. And some of you may have actually picked up some of the forms already that were outside the auditorium. So jumping back, we were just talking about 2017, but jumping back to 2008 for a moment. There was a peanut consumption study that was evaluating peanut allergy in Jewish children in both the United Kingdom as compared to in Israel. And it was known that peanut allergy prevalence was a lot higher in the United Kingdom and compared to Israel. So there were about 1.8% of children in the United Kingdom with food allergy as compared to, as you can see, almost none in the Israeli population. And when they were evaluating the differences among the populations, it became very clear that the Israeli infant population was consuming large amounts of peanut, actually over 7 grams of peanut protein in a given month, compared with the UK's consumption in infants of 0. So this led to this sort of landmark study, the LEAP study, about prevention of food allergy with early introduction of peanut. So the LEAP study looked at a little over 600 children in the United Kingdom, and they enrolled kids that were aged 4 to 11 months, and they were looking at a high-risk population, so those specifically with severe eczema, egg allergy, or both. And then they assigned those children into 2 groups, or also called cohorts. The first group was the regular consumers of peanut, as you can see, my top one there. And the second group was the strict avoidance group, meaning don't eat it now, don't eat it later, let's watch you and see what happens. So they took these 2 populations, and the ones that were randomized into the consumption group were asked to consume 6 grams of peanut protein per week. And then they continued to go along doing this, and it was important, again, to have regular consumption over time. And they followed these groups until about 5 years of age, at which point they looked at the incidence of food allergy in the 2 groups. So in this study, the investigators concluded that at 5 years of life, with regular consumption of peanut from an early age, the development of peanut allergy could be reduced by 80%. This was in all trial participants, actually. But if you think about a clinical trial, not everyone follows the rules. So some people get told to eat 6 grams per week. They may not be able to keep it up. So if you actually look at what they call per protocol analysis, meaning which of the participants actually kept it up, the data is striking, and almost 0% of the peanut consuming population that kept it up over those 5 years had peanut allergy at the end. This LEAP study was really considered to be just a significant trial and a significant discovery for food allergy prevention. There were several weaknesses, though, as we moved forward in understanding food allergy prevention. First was this was in a high-risk population. So again, it looked at patients that had either severe eczema, egg allergy, or both. It also, unfortunately, only studied peanut. So what about the other 7 allergens, for example? It also said you have to eat 6 grams per week. What if we only need less than that? Okay, we don't know the answers to all of those questions come 2015 when this was published. And at the time, that was when the AAP was saying, hold up, we made a mistake, but we're not going to give you guidelines just yet because we're not sure we entirely understand what you should be doing. So the LEAP trial, as I mentioned, was in high-risk infants looking at peanut, and so they identified these sort of follow-up questions. So does early introduction of these other allergenic foods, so you can see on the left here, Will that also reduce the incidence of food allergy? And how about in a regular population? Are we going to see the same things in the regular population as we do in the high-risk population? As you can see, the United Kingdom also ran this sister trial. It was called the Inquire About Tolerance Study. And it was performed and enrolled over 1,300 infants, starting at age 3 months or so. And these ones were all considered regular risk, so general population. And they assigned those, again, into 2 groups. And the first group was early introduction of 6 allergenic foods. And this was sequential. So they all started with milk first. And then following that, the family could randomly put in the other 5 foods. And those included peanut, egg, sesame, whitefish, and wheat. If you were not enrolled in the early introduction group, you were put into the exclusive breastfeeding group. And in that group, the families were asked, please don't give anything until 6 months of age. And at that point, you can do what you want. You can introduce at 6 months, you can introduce at 9 months, you can introduce at 12 months if you want. And we're going to follow you and look and see what happens. So they followed these children over 3 years' time. And I'll get into the follow-up in a second, but as you can see, they discovered that at 3 years, there was no significant difference in the, between the 2 groups. And so the early introduction group had about, this is actually pretty high numbers, but 5% allergy compared to 7% food allergy in the group that was strictly avoiding or exclusively breastfeeding. But before you get thinking, oh, wait a minute, everything I'm telling you is ridiculous and that maybe we shouldn't be doing this, there were some protocol problems. They asked these families to introduce a large number of foods. And it's important that you regularly feed these things to your children, right? So there was a huge problem with protocol adherence. And actually only about 50% or less, or fewer, of the families were actually able to keep up with it. So when you're looking at this data here, they're showing all comers, everybody in the trial, whether you were able to keep up with the strict diet or not. And so they lacked significance. You can almost begin to think that you're seeing a difference between the 2 groups, but there was not significance. However, when the investigators went back and analyzed the data, and they looked at those that were adherent to the protocol, they did in fact notice that there was a significant reduction in food allergy. So here you can see that we're talking about 2% and change in the early introduction group compared to, again, 7% in those that were exclusively breastfeeding. So that looks promising, right? Actually, it's even more promising than that. So they looked even farther and they looked at peanut and they looked at egg. And those ones in particular showed a really, really impressive, like 0% in the peanut group and something like 1.5% in the egg group for allergy. So there's something here. And though the big conclusion, I guess, you can take away from this is even though sequential early food introduction in the standard risk doesn't significantly decrease the prevalence of allergy, we're talking about significance here, this could all be due to poor adherence. And at worst, if you think about this, these findings maybe suggest a non-inferiority, meaning it's not worse if you introduce foods early. And the data actually showed that it was very safe to even be doing so. And so at best, you can say that there is a protective effect from doing this. So in 2017, that's when the guidelines came along from the NIH. And they stratified infants based on risk. And so they were looking at the top is your highest risk group. Those ones had severe eczema, egg allergy, or both, and that came from the LEAP study. And at the bottom is your lowest risk, and those ones have no eczema at all or any food allergy. And then there's some that are in between, maybe your mild eczema, things like that. It's also worth mentioning that in this, what they call severe eczema, that means, let's say your child has some eczema, you're going to the pediatrician, you're getting topical corticosteroid, and you're using it frequently, that is severe eczema. If you have a little bit of eczema, and you're not having to use much medication for it, that kind of puts you in that middle category. So let's say you're in the high-risk group. The recommendation for those infants is to strongly consider an allergy evaluation by blood test or skin prick test, and with the goal being to introduce peanut-containing foods at an early age of 4 to 6 months. In the medium risk group, which may have a small amount of eczema, the recommendation to introduce peanut is without prior testing, and this can be around 6 months of age, and that's mostly because they're considered to be at less of a risk for food allergy. And in the low risk group, the NIH basically didn't change the recommendations. They just said you can do it at whatever your family wants and whatever's within your cultural practices. So the guidelines talk about the introduction of peanut-containing foods, but as you know, whole foods and even whole nuts and even spoonfuls of peanut butter can be choking hazards. So it's crucial that you offer baby-safe versions. And examples of this can be thinned peanut butter or peanut protein or powders or flours or baby-friendly nut puffs or snacks. And so while preaching about, baby-safe nuts is great, what does this mean in real life? How much are you supposed to be giving to your children? So the LEAP study, again, was based on 6 grams per week of peanut protein. And we don't know that the 6 grams is the necessary amount, but that's what we're working with at this point. And it's worth, discussing how much this means you're actually putting into the child per week. So this actually translates over the course of the week to about 6 teaspoons of peanut butter, or 6 teaspoons of peanut powder, or about 60 total peanut puffs or snacks. And you want to be giving this regularly, so then the recommendations get broken up even further and say, okay, well, how much over a given day is this? And it's about, if you plan for about 3 days a week, it's about 2 teaspoons full of peanut butter on a given day. And so you may have picked up one of the guidelines on the desk outside, and it was published by the NIH and the NIAID. And that is essentially giving you information on how you can put these foods in your diet. So they include instructions on safely feeding the peanut snack, thinned peanut butter, either by putting it in water or puree, or mixing the peanut powder into a puree as well. So you can pick up a copy of this for yourself or your friends when you head out if you don't already have one. So unfortunately, the guidelines don't address all scenarios, obviously. So for example, what if your child has a milk allergy? The guidelines talk about egg allergy and eczema. But what risk is your baby in if you have, let's say, a milk allergy and no prior exposure to egg and no eczema? And how do you introduce peanut to that child? So at this point, we're saying, okay, your baby with milk allergy probably also is in the increased risk category. And again, we would strongly consider allergy testing and then subsequent hopeful early introduction of peanut. So I'm up here preaching about early introduction of foods, and this commonly comes up as a question. Well, doesn't the AAP and the World Health Organization recommend 6 months of exclusive breastfeeding? Early food introduction, in fact, does contraindicate AAP and World Health Organization recommendations. I'm standing up here as a pediatrician, as a mother of 2, actually as a daughter of a certified lactation consultant, and I want you to know that I entirely support breastfeeding for 6 months or longer if able. But the breastfeeding guidelines were not designed with food allergy prevention as a key goal. They were in fact designed with obviously other outcomes, such as gastrointestinal infections, respiratory tract infections. And so when you look at the main benefits of exclusive breastfeeding for beyond 3 to 4 months, we're talking about reduced morbidity from GI and respiratory tract infections. You're also looking at, for example, more rapid maternal weight loss after delivery and delayed resumption of maternal menstruation, not prevention of food allergy. So while early solid food introduction is not intended, obviously, to replace breastfeeding or formula feeding, it is certainly something to think about, but we've got to use common sense a little bit. I'm sitting up here telling you to give 2 teaspoons full 3 times a week, starting at age 4 months. Let's be practical. you're not going to be able to do that. So we really need to think about what works for a 4-month-old and then increasing that over time. So as you're doing this and safely trying to introduce to a child, you're going to be using a small amount. Start with a taste. And, you know, at 4 to 6 months, again, food is for discovery. It's for exploring. It's for possibly prevention of food allergy. But obviously, I still want you guys to understand that breastfeeding and formula is the main source of nutrition. And while on the topic of breastfeeding, several audience members submitted some questions ahead of time and wanting to know about breastfeeding diets in particular. So the question being, should breastfeeding mothers be eating or avoiding allergenic foods if they're hoping to reduce food allergy in their infant? There have been many studies that have been done thus far on this, and some of them, in fact, have been contradictory. And at this point, there is no landmark study that I can stand up here and talk to you about that's going to tell you specifically what you have to do. But at this time, we're recommending essentially a balanced diet that includes all of the allergenic foods. Basically, eat what you want. If you want your peanut butter sandwich, go for it. And then what about during pregnancy? Again, is there anything you can do during pregnancy to prevent food allergy? And the advice is the same. We recommend a normal diet without restrictions when you can. And overall, it's just worth mentioning we advise against elimination diets unless they're going to be under the strict sort of supervision of a physician, just because there is a risk, obviously, of nutritional deficits and things. So in summary, based on current data, when we're looking to reduce the incidence of food allergy, the recommendation is for early introduction of allergenic foods, including but probably not limited to peanut, starting as early as 4 to 6 months based on risk. So if your infant has severe eczema or other food allergy, obviously strongly consider allergy testing prior to the food introduction. As I mentioned, start small, start with a taste, and if there's no reaction, move forward, moving up to the amounts that we have recommended for peanut. And at this time, with regard to breastfeeding and pregnancy, the literature recommends against exclusion diets. So go ahead and enjoy what you want. And that's it. So happy eating to your little ones.
And then one thing we wanted to add too is if once you start introducing it, you actually need to keep it in the diet because if you maybe introduce it one time at 4 months and they don't see it again for a year or two, it can actually worsen their chance of a reaction.